Welcome back, everyone. We have the pleasure of having Dr. Philip Ovadia with us today. Thanks so much for joining us.
Yeah, it's great to be here with you, Ben. Happy to have a conversation with you and your audience.
First place to start is, how do we stay off your operating table? And I'd like to frame it in a slightly different way, which is, what would the consensus opinion be to stay off your operating table as a heart surgeon? And then what would your opinion be?
Yeah, so I'll start with the consensus opinion, and I'll tell you that the consensus opinion has failed, is failing. And the evidence of that is how busy I am as a heart surgeon. I've now been a heart surgeon for over 20 years. And it was interesting when I was doing my training, which was, late 1990s, early 2000s, and I was deciding what specialty to focus on. And when I decided on heart surgery, many of my mentors told me that I shouldn't go into that because this was right around the time when, statins, had come on the market, were the most widely prescribed class of medications. And it was believed that heart disease was going to be significantly reduced and essentially eliminated over the next 20 or so years. And they said, you're going to find yourself without anything to do. Here I am 20 years later, busier than ever. Here in the United States, we actually have a shortage of heart surgeons. There aren't enough heart surgeons to go around and do all the surgery that needs to be done. So heart disease remains the number one killer far and away in the US, in the UK, worldwide. And obviously, we're not making great progress against heart disease. Now, again, the consensus opinion is centered on cholesterol. They believe that cholesterol is the driver of heart disease. It's what's causing the problem. And the solution is lower your cholesterol, either with pharmaceutical approaches, statins, PCSK9 inhibitors, all those medications, and or lifestyle interventions. Eat a low-fat diet. Avoid dietary saturated fat and dietary cholesterol to try and keep your blood cholesterol levels down. And that's been the prevailing consensus for really the past 50 or 60 years that we've been talking about cholesterol as the cause of heart disease. And clearly, that is not working. And that's part of what led me to, I guess you could call it, my alternative hypothesis around heart disease. And again, I didn't discover this. I didn't, make any groundbreaking discoveries. I just started to put the pieces together in what I was seeing in my practice, and even as it comes to my personal health, which we can talk about at some point. But I now realize that the root cause of heart disease is insulin resistance, metabolic health, and inflammation. And those are the things that we need to address to be able to keep people off my operating table. And the important thing I want people to understand, I want your audience to take away from this, is heart disease is preventable. You can stay off my operating table. I now realize that the majority of the operations I do are failures. And they're not failures of the patient, they're failures of the medical system, because we should have been able to prevent it from getting to the point where they now need a major intervention like open heart surgery.
Wow. It's a really interesting journey, because I imagine the medical world you trained in and grew up in when you were coming through as a young doctor, right, was very much we treat to you when you have a problem. And there's been this fundamental shift, and it's happening quite quickly over the last 5 to 10 years, right, where it's moving away from that reactive to more towards acknowledging this preventative side of the equation. Another question for you, slightly broader, before we dive into your own story, which I'd love to get into. Do you believe most diseases are metabolic in nature? Not all, but most.
Yeah, certainly when we look at the chronic diseases that people suffer from, right? And the big ones, heart disease, cancer, Alzheimer's disease, these are all metabolic related. Even when we start getting into things like the neuropsychiatric disorders that people are suffering from, those we are discovering are metabolic in nature. So I do believe that metabolic disease metabolic, health is the key to preventing and managing chronic diseases. Now, when you look at acute diseases, things like infections, they may not be metabolic diseases per se, but having poor metabolic health certainly puts you at greater risk of those things. We all, of course, are hopefully at the tail end of the COVID saga, right? But one of the things that was most apparent earliest on, those first cases out of China and Italy and New York, if people remember back, was that the people that were metabolically unhealthy, the people with diabetes, the obese, these were the people that were most likely to get COVID and then most likely to suffer the severe consequences of COVID, die, get very sick, need to be in intensive care. It was metabolically unhealthy people. So metabolic disease really does underpin the vast majority of what we deal with in medicine. And again, if we're going to solve a problem, we need to understand the root cause of that problem.
Absolutely. It's been a really interesting journey over the last, I guess, 8 months. 8 months ago, if you said to me, most chronic diseases are metabolic in nature, I would have had a lot of pushback from things you've already heard. But speaking with the likes of yourself and Thomas Seyfried and Mary Newport, when it comes to the sort of cognitive degradation piece, it just keeps cropping up over and over again. Actually, the metabolic psychiatry angle you mentioned is super fascinating world. So when it comes to the heart, the human heart, you were operating for a number of years in a, you were 100 pounds heavier, right? And I assume you probably weren't in the state of metabolic thriving, or I guess you're probably in a state of metabolic dysfunction. Would you agree with that?
Very much so. I was pre-diabetic, I was morbidly obese, and I came to the realization, right, that I was headed for my own operating table, so to speak. So, this started, you could say, selfishly, right? I needed to fix my own health. And that's ultimately what led me to these conclusions, to discovering this different information. Like I said, it wasn't that it was new. It wasn't that I discovered it. It was just a matter of, as we go through our medical training, as I was in my career, this information doesn't get talked about. It doesn't get kind of filtered down to the doctors. So for the vast majority of doctors out there practicing, it's not any sort of malintent that they don't pay attention to metabolic health. It's true ignorance. They don't hear about it. They don't know about it. And therefore, they can't offer it to their patients. And I had to, really go outside my typical kind of circles of information. I had to start asking different questions. I had to be open to, the counter narrative, I guess you could say, right? Learning the sort of holes that were in the dogma that I had been taught, that I had just been, accepting as truth. And it was only when I started asking these different questions and coming across this different information that I was able to first improve my own health, lost the 100 pounds, reverse my pre-diabetes, and then start to realize the power that this could have for helping my patients as well.
Did you have a tipping point specifically related to your own heart, or was it actually, I just need to lose some weight? And did you put the two and two together when you started to lose weight?
Yeah, I mean, I didn't get to any sort of crisis point. I didn't have a heart attack or anything like that. It was just like I said, I had this realization, right? I was a young father and, thinking about that I was going to be headed for heart disease. I looked exactly like the patients that were on my table, basically, and I was developing those same problems. And again, at the time, I didn't really make the metabolic connection, but things like being pre-diabetic and being morbidly obese were obvious to me. And what I realized was, I didn't know how to fix it, because the advice that I had been educated to give my patients, and it's the advice that, your audience will have heard, right? Eat less, move more, eat a low-fat diet. It wasn't working for me. And it wasn't working for my patients, obviously. And that's what led me on this quest to figure out what else can or should I be doing.
Okay, so I'm trying to put myself in the audience shoes, and if they're hearing the link between metabolic dysfunction and heart disease for the first time, I think it might be helpful to zoom out at the start of where a healthy heart goes wrong from the metabolic health point of view. So if there is let's say he's a guy in his mid 40s and he has previously, had a pretty good heart throughout his whole life, right? No signs. What is it about poor metabolic health that starts this cascade of the better increased odds of a cardiac event?
Yeah, great question. So, first of all, to frame the conversation properly, right? We're talking about atherosclerotic heart disease, a buildup of plaque in the arteries of the heart that eventually can reduce the blood flow through those blood vessels and put the muscle of the heart at risk, right? A heart attack is when you can't get enough oxygen to the muscle of the heart to meet its demands. And this is the most common form of heart disease. Understand, it's not the only form of heart disease, but generally when people talk about heart disease, that's what they're referring to. Atherosclerotic heart disease is kind of the more technical medical term. So the problem is this plaque that builds up in the arteries. And then we have to ask, why does the plaque build up, right? And again, the traditional thinking was that the plaque builds up because of the cholesterol in your bloodstream. And this made sense because when you look at the plaques under the microscope, they have cholesterol in them. And so that's what led to the conclusion. And, I can understand thinking that that was a valid theory. What that misses is, why does the plaque start, right? And really what needs to happen for that plaque to start is the blood vessel itself needs to be damaged. We have a lining inside the blood vessel that the blood is in contact with. It's called the endothelium, right? It's a lining of cells that protects, that keeps things from the blood generally, right, from getting into the wall of the blood vessel. The blood vessel, is a structure and it's got a wall and it's made up of connective tissue and muscular tissue. And, there are all sorts of cells and stuff that are in there, right? And things are constantly moving back and forth between the blood and the wall of the blood vessel and then out to the tissues around it. Nutrients and all sorts of things do that, but they do so in a regulated way. And where this starts to go wrong is the endothelium gets damaged. And now the regulation of what is moving, out of the blood becomes disrupted. And more of these cholesterol particles can start to move through there. And in fact, the cholesterol particles are attracted to areas where the endothelium is damaged, because cholesterol, one of its purposes in the body is to repair damage like that. It's kind of like the spackle that you put on your wall when the wall gets damaged. So going back to what damages the blood vessel, that's what really leads us to the keys of heart disease. And it's things like high blood sugar, right, which comes from the metabolic dysfunction. So that's one reason that metabolic dysfunction leads to heart disease. It can be other toxins. This is why smoking, for instance, leads to heart disease, because it also damages that endothelium. The other thing that metabolic dysfunction does, insulin resistance, as we call it, is it actually damages the cholesterol particles themselves. So when things are working well and you get some damage to your blood vessel wall, cholesterol comes along, repairs the damage, and then it sort of dissipates, it melts away, and you're back to a state of a healthy blood vessel wall. And that's probably something that's going on all the time, right? Because there are so many things in our environment that can damage the blood vessels. But when insulin resistance and metabolic disease occurs, the cholesterol itself gets damaged. And now when that cholesterol, that damaged cholesterol, goes to try and repair these things, the body reacts to it because it's damaged, and it sets off this inflammatory response. And now that normal healing process can't occur. And this is when the plaque starts to build up.
Okay.
So in the end, cholesterol is part of the process. And, maybe you can have some effect by lowering the amount of cholesterol. But if you really want to fix the problem, you want to prevent the damage to the blood vessel and you want to prevent the damage to the cholesterol itself. And that's what leads us back to the metabolic disease, the insulin resistance, and the inflammation that goes along with it.
Okay, so in a metabolically healthy person versus a non-metabolically healthy person, cholesterol in the healthy person is part and parcel of repairing wear and tear on the endothelium. And am I
Correct.
right in saying cholesterol is needed in any, apart from red blood cell, is needed in the creation of any new cell in the body?
Yeah, so the wall of all of our cells have cholesterol within them. Cholesterol is very important in our immune system, helping us to fight off infections and even things like cancer. And cholesterol also is a precursor molecule for many of the vital hormones in our body. Things like vitamin D are made from cholesterol. Vitamin D, by the way, is a hormone. It's not a vitamin. It's misnamed. Testosterone, estrogen, progesterone, cortisol, all of these things are made from cholesterol. And so cholesterol is essential. We cannot live without it. We wouldn't exist without it. And that's another kind of part of the problem of this whole cholesterol hypothesis. If the goal is to basically try and lower cholesterol as much as possible, what other negative effects might that be having?
So elevated cholesterol is only a problem if you're metabolically unhealthy.
Yes. So again, and this is something that's been demonstrated in the studies, that if you don't have insulin resistance and you don't have inflammation, high cholesterol is not problematic. We actually have some, we'll call it breaking data on this, right? There was a study that just came out earlier this week as we're recording this. It's from the work of Dave Feldman, Nick Norwitz, Dr. Matt Budoff, Dr. Adrian Sotomayor. And what they did was they looked at a group of people with very high cholesterol levels, but did not have inflammation or insulin resistance. These were people on low carbohydrate diets. It's a phenotype we call the lean mass hyperresponder. Exceedingly high cholesterol levels, LDL cholesterol levels that were in the 300 plus range. So that's US units, but we'd be talking probably, 8 to 10 millimole, right? Very high levels, maybe even a little higher. I'd have to do the math on that. But they looked at these patients over a year and they did advanced scanning of their heart to look for plaque. And what they essentially found was that these patients did not have any increased amounts of plaque compared to people that had normal cholesterol levels that were roughly the same. And then over the year, they did not accumulate more plaque significantly despite having these very high cholesterol levels. And finally, what they demonstrated was their blood cholesterol levels had no correlation to how much plaque that they had or how much the plaque progressed over the year. So we see this, decoupling, we'll call it, between cholesterol and the actual plaque. And this is honestly another issue we have when we're dealing with heart disease. Most physicians are under the impression that cholesterol, blood cholesterol levels, either total cholesterol, LDL cholesterol, sometimes you'll hear ApoB talked about, which is a different way of measuring cholesterol, but that these things actually measure and predict how much heart disease one has. And it's not true. If you want to know how much heart disease someone has, you need to look at the blood vessels. And we can talk about ways of doing that. But that's one of the other things I talk about that maybe kind of diverges from the standard. I don't want to look at the blood work necessarily, especially when it comes to cholesterol. I want to look at the blood vessels and actually see how much disease is there.
My understanding is the endothelium is underpinned on a foundation of mitochondrial health, which in itself is directly correlated with metabolic health. if might be oversimplifying grossly, but I hope I'm not. Can you just talk to the link between the endothelium and metabolic health as a whole before we sort of dive into it?
Yeah, so I already mentioned a few things, right? The high blood sugar that can accompany metabolic disease leads to damage to the endothelium. The inflammation that accompanies metabolic disease damages the endothelium. But there's even more linkage. One of the body's most important substances in in helping the endothelium to remain healthy is something called nitric oxide. And maybe, many in your audience may have heard of nitric oxide. It turns out that metabolic dysfunction interferes with the production of nitric oxide. So people with metabolic disease have lower levels of nitric oxide, and that is another thing that, uh, threatens the endothelium in people with metabolic dysfunction. So metabolic dysfunction, insulin resistance, right, have many different pathways by which they lead to the heart disease. And that's what's so interesting about it, right?
Mm,
And again, this is only talking about heart disease. We haven't even touched on, but I know you've had other guests that have touched on, right, what metabolic dysfunction does to the brain, leading to cognitive dysfunction and Alzheimer, why metabolic dysfunction can lead to things like cancer, that Professor Seyfried does such a good job of explaining. So one of the interesting things about this journey for me as a heart surgeon, right? I didn't think I was really going to be, getting outside of my area of heart disease, but the great sort of side effect, the great benefit to focusing on metabolic disease is that by helping the patients with a focus on heart disease to improve their metabolic health, we're addressing all of these other areas as well.
it's a wonderful message. It almost seems a bit too good to be true, but you dive into literature, and hey, maybe it's how we were meant to evolve. The,
Exactly.
do you believe that? Do you think we're meant to? I guess it's sort of spoiling the surprise, I guess. But do you think we are meant to be in a state of ketosis more often than not?
Yes, I do, and this is the environment that we would have evolved in, right? So it makes sense that our bodies became optimized for that environment. You know, uh, when we go back, on the evolutionary scale, right, carbohydrates would have been very small, limited part of our diet, seasonal at best, right, and especially depending on where you were in the world. But it would not have been the major part of our diet as it is today. So we also would have been fasting a lot more, right? We wouldn't have
Mm,
been eating as often. And those are all things that lead to a ketogenic metabolism. Fasting and low carbohydrate intake is basically what leads you to a ketogenic metabolism. So we would have existed primarily in a ketogenic state. And now we don't. And that really is one of the central underpinnings of why we get this metabolic disease.
yeah, it's funny. So my dad, he's fluctuated with his weight a lot in his as an adult, and about around 2015, 16, he was getting to a point where it was like, okay, I've got to do something about this now, and he started doing quite lengthy extreme fasts. So he won't eat for 4 days, and then he'll eat again. And he's doing this for a number of years, and he lost a load of weight doing it. But yet I'll still say, you should explore the keto stuff. And he's like, okay, fine. Well, isn't keto really high fat? And I say, yes. He's like, well, no, I can't do the high fat stuff because, my cholesterol, can't do it. Not good. And it's very hard to sort of to break through a little bit. But the caveat of what they say, or what my dad says to me, which I actually don't have a good answer for, is what about Atkins? Atkins started the high fat stuff, and yet he died of a heart attack, right? What would you
So
say?
he did not die of a heart attack, right? This is
Does he not?
misinformation that's out
Ah,
there. He slipped on the ice, right? He had a head injury. He was in the hospital, for an extended period of time. And, he was very sick because of that, right? And they say he died of a heart attack, but he really didn't. His
oh wow.
organs failed. Maybe that included his heart, but the statement that Dr. Atkins died of a heart attack is completely false. And it's one of the things that's put out there to try and counteract this narrative. But I can tell you it's not true. And, again, we're battling against this 50 years of this misconception that so when we go back to the diet heart hypothesis, right, as it was, kind of developed mainly in the 1950s, right, it's a two-part theory. Part number one is the more dietary cholesterol, and maybe you can extend that to dietary saturated fat you eat, the higher your blood cholesterol level is going to be. And then that increased blood cholesterol level is what leads to the heart disease. And it turns out that both of those are false, right? We already kind of talked a little bit about high blood cholesterol doesn't always lead to heart disease. But it also turns out that eating the amount of dietary cholesterol and the amount of saturated fat that you consume is a very small determinant of what your blood cholesterol levels end up being. Most of the cholesterol in our blood is being made by our liver and being recycled in our body. And the amount of dietary cholesterol actually has very little to do with what your blood cholesterol levels end up being. So, this is where we get the sort of, this is the misinformation, I'll say, that we need to counteract and get out there. I see patients who they switch to keto, carnivore, low carb, whatever you want to call it, type diets, and their blood cholesterol levels stay the same or even go down in some cases. Some people it goes up. In a lot of people, when it goes up, that's a temporary phenomena. When you're losing weight, your blood cholesterol levels tend to go up because as all those fat cells are breaking down, right, that those fatty acids are now being trafficked through the blood. And so the cholesterol carrying particles increase. But when your weight stabilizes, it often comes back down to those same levels you were at. And the larger studies that have looked at ketogenic diets, low carb diets, on average, the blood cholesterol levels don't change.
That's a fascinating piece of misinformation because it's so prevalent. People always hear Atkins died of a heart attack. The irony, right? It is amazing, and an interesting piece of misinformation for sure. When it comes to reformulating, or I guess repositioning fat in the mind of people who have grown up where fat is, got to avoid saturated fat, high fat diets are going to kill me. How do you think about going about that?
Yeah, it's probably the biggest challenge I face, in my medical practice and with the people I deal with every day, because we've all heard it our entire lives at this point. And the only thing I can do is put the evidence in front of them, right? And that evidence, first of all, is, kind of the things we've been discussing, but it's also if you're willing to give it a try and see what happens. And in the end, we oftentimes can end up in sort of an interesting point in the discussion, right? Because I oftentimes have people who come to me and they've already been doing this, right? And they've gotten great results, right? They went on the low carb diet, they lost a bunch of weight, they cleared up, all sorts of problems like diabetes or, skin conditions. Their mental health is better. They're having all this energy, right? And they feel great and they love what they've been able to accomplish on this diet. But they go to their doctors and the doctor says the same thing to them. You can't keep doing this. It's going to kill you because of all the saturated fat and cholesterol you're eating. And maybe even their blood cholesterol levels have gone up. So the doctors, scare them. And they come to me and, I actually sometimes have the direct conversation. I say, let's assume that that's true, what the other doctor told you about the risk to your heart. If you could make the trade-off, if it's truly a trade-off between you can feel as great as you've been feeling and you might get heart disease, you might die of a heart attack, a little bit earlier, versus you can go back to feeling miserable but you're not going to die of the heart attack and you're going to live a little bit longer. Which would you choose, right? Quality of life versus quantity. And the vast majority of people say, I'd rather feel good for the time I had and maybe have a little shorter time than, spend the last part of my life miserable and sick, even though your life might be longer. Now, the good news is that that's a false dichotomy. That isn't the choice we need to make, because this isn't harmful to your health. And the evidence behind that continues to accumulate every day. I see it in my practice every day. So you don't have to make the choice. You just have to now understand that what you thought you knew about heart disease and what your doctor thought they knew about heart disease isn't true. It never was. And that's very hard for people to accept, that, what they've heard as fact for their entire life is not true. But unfortunately, I'll say heart disease isn't the only place that exists. And we see more and more every day, right, that these kind of big narratives that we're told are true are turning out not to be true. And so ultimately, I just encourage people to be open-minded, right, and to be accepting that these things that they were told were true are not true.
Yeah, I mean, it gets quite Darwinian, right? Where you have to kill your best loved ideas, and easier to do that on an individual level, harder to do it on a group level, especially when a lot of the people who have to accept this have spent their whole careers learning a certain school of thought, and to change their minds is psychologically a real test, and it's hard to do. What is the line? Is the human mind works like a human egg. Once sperm gets in it, it shuts off. And I often find that is true when talking about sort of non-consensus but correct worldviews like this, right? What would you say to someone who maybe is in their, I don't know, let's say their early 40s up to late 60s, and they're hearing this for the first time now, and they're thinking, oh, maybe it's too late for me, right? I've already got plaque in my heart. Like, how surely it can't be that effective. What would you say?
Yeah, I would say, don't believe that, right? And I see it now every day in my practice. So understand that no matter where you are, right? No matter how bad your heart disease might be. And I have patients who have already had stents, already had bypass surgery. We can stop it from getting worse, and we can start to see some reversal. And I see this in my practice. We have patients that are able to lower the amount of plaque in their blood vessels. Now, my general goal is just stop it from getting worse. And that, again, we see consistently when people start paying attention to these metabolic issues. When you take care of the inflammation, when you take care of the insulin resistance, the plaque stops getting worse. And then in some cases, it can actually start to reverse. And no matter how bad you are, right, we just need to stop it from getting worse, because the natural history of heart disease is it does progressively get worse, right? Despite all the medications and everything like that, the vast majority of people that are diagnosed with heart disease, and maybe they get a stent, maybe they've had a heart attack, maybe they get bypass surgery, they still end up dying of heart disease. Yes, we have better treatments for heart disease today. So those patients live longer than they used to, right? Heart attacks used to be, have a very high fatality rate. Today, that rate is much lower, the number of people that die from their heart attack. And we can keep them alive longer, and we can improve their quality of life with, these treatments, but they still end up dying of the heart disease because no one ever addressed what was causing the heart disease in the first place.
So then we get back down to, okay, metabolic health, right? What do you think are the biggest levers on one can pull to get metabolically healthy?
Yeah, so we already talked about two of them, right? One of them is eating less carbohydrates, particularly processed carbohydrates, which includes sugar. The other is eating less often, right? Fasting can be a great tool. And then I throw in activity and exercise, very important, and particularly building muscle. Muscle is a very metabolically active tissue. And the more muscle you have, it becomes easier to maintain good metabolic health. Some other things to think about are getting good sleep, very important to metabolic health, and getting sunlight, also important to metabolic health. So those are kind of the pillars that I talk about. People always ask, okay, what's most important? What do I do first? And really, the diet is the most important thing. When you are metabolically unhealthy, if you've already gotten to that point, your body cannot properly process carbohydrates, and you need to eliminate them as much as possible, give your body a chance to recover. Now, if you've gotten to this before you're metabolically unhealthy, or you're now recovered and you've improved your metabolic health, yeah, there may be some room in the diet for some non-processed carbohydrates. But while you're metabolically unhealthy, you got to eliminate the carbohydrates as much as possible. And then fasting becomes a great adjunctive tool to use as well.
It's always funny I'm sure you've seen this loads, when you look at people's high sensitive C-reactive protein when they're in a state of ketosis. Often it's pretty negligible, right? It's
Yep.
non-existent. Is that consistent with what you see?
Yes, definitely so. The low carbohydrate, non-processed diet leads to very low inflammation pretty consistently.
And you mentioned at the beginning, but it's this inflammatory sort of sinew we have in our whole body that leads to this problem in the endothelium. So, what is it? Is it my understanding is that the inflammation actually oxidizes something, or could you clear this up for me? I don't know if you know where I'm going with this.
Yeah, that's where we get back to the damage that's done to the cholesterol particles themselves, right? Oxidation is kind of one of those forms of damage that we're concerned about. And when that damaged, right, that damaged cholesterol then sets off this secondary inflammatory reaction within the wall of the blood vessel itself. So that's one of the reasons, again, why inflammation and insulin resistance are so problematic.
Okay, that's helpful. So to get metabolically healthy, like all those levers people are pretty familiar with, right? What would you say if someone's saying, okay, doc, I've got keto and I've got this carnivore thing that I keep hearing about, you only eat meat, this carnivore diet.
Yep.
Are they the same? Are they different? How would you answer that question?
Yeah, I say they're really, different forms of the same thing. So, and there are some things, we should talk about, right? So, ketogenic diets in general just mean that your body is primarily using ketones, which come from the breakdown of fats, for energy, as opposed to using sugar as its primary energy source. And understand these things are never 100% one way or the other. Our body's always doing some of both. It's just sort of what's the primary thing that it's doing. Now, there is what I call the therapeutic ketogenic diet, right? This was the original ketogenic diet developed really going back to the 1920s, although some people talked about similar concepts even before that without really knowing what ketones were in all of this. But it was originally developed to help with epilepsy, right? Seizures, a neurologic condition. And they discovered that when you get into this ketogenic state, the brain metabolism improves, settles down, and you can keep seizures at bay. Now, that's not quite the same thing as, the keto, kind of the popular keto diet that people talk about today. The popular keto diet today is a low carb, high fat diet. It's the true therapeutic ketogenic diet is actually exceedingly high fat. It's low carb, and it's also fairly low on the protein, and that's the big difference. And there's some problems with that, right? Because you need protein as well as the fat to really thrive. So, carnivore, right, is kind of the lowest carb diet that humans can eat. It's not quite zero carb. It can be. It depends on what you're eating, but dairy is going to have some carbohydrates. Some of the organ meats are going to have some carbohydrate. But carnivore ends up being a very low carb diet. It's a form of a ketogenic diet, right? You're going to be in a primarily ketotic metabolism because you're not eating carbohydrates. And, it has some other unique advantages to it. And when we're dealing with conditions like autoimmune conditions and inflammatory conditions, the carnivore diet can have some unique advantages to it that maybe a keto diet that's incorporating some plant products won't have. So I always tell people they are both good options, right? One of the things that I sort of need to do as a heart surgeon is say, you can eat all the red meat you want. It's not going to damage your heart, right? And that's always one of the fears that people have around when you start talking about, carnivore diets and even keto diets, which for most people are high in animal protein. Although I do know some people that do, plant-based ketogenic diets, kind of challenging, but it can be done. So those are the different options, right? And I don't think that there's one right answer. I don't think that it's necessarily true that a carnivore diet is better than a keto diet or better than a general low carb diet. That's where the personalization needs to come in. And we need to talk about, and this is what I do with patients. We talk about, what are your preferences? What problems do you have that we're trying to address? And that's going to start to direct us towards which of these options might be better. But I put them all on a low carbohydrate spectrum. And the other key thing, right, and this can be a problem, is it's got to be based in eating whole, real food. Because if you're getting, even on a keto diet these days, right, there's lots of processed food that you could introduce, and they might have things like vegetable and seed oils. They hopefully don't have sugar, although some of the products that are labeled keto do. But, you're avoiding the sugar, you're lower carbohydrate. But if you're still doing that with a lot of processed food, that can still be pro-inflammatory and still lead to problems. So for me, the way that I talk to people about constructing your diet is, first, you want to make sure it's all whole, real food. Then you want to make sure it's relatively low carb, and how low carb it needs to be is going to depend on where your metabolic health is. And then you want to think about, do I have some unique, thing like an autoimmune condition, for instance, or really bad inflammation that may prompt me to go sort of down the carnivore route. And that's kind of how I think about that and set a framework for my patients.
Brilliant, super clear. So I would guess that what I was trying to tease out, and you put it perfectly, was they're kind of two doors to the same house, right? You're going to be in a better metabolic state doing carnivore or keto than you would if you weren't to do that. And I guess it's refreshing, or not refreshing, but it's interesting to note that the benefit isn't teased out from the elevation of high ketones, right? So you don't have to track your ketones to be above 3 millimolars every day. Because I assume that even if you're in carnivore, your blood concentration of ketones would be circulating a lot lower from the natural spike that would happen with high protein. So it sounds like the benefit isn't off elevation of high ketones as such.
Correct. The ketone levels can vary some on carnivore diets, and they may not get to those high ketone levels, like you said, because of the amount of protein and also because of the amount of fat, right? Because of the way that meat is processed these days, it's not a particularly high fat food, right? Which is kind of ironic, right? People always think of, meat is so fatty, but realize that, because of this fear around fat, right? We trim a lot of the fat off. And it turns out that even like a ribeye steak, right, which is kind of more fatty than most other steaks, is only about a 1-to-1 ratio typically between grams of fat and grams of protein. And that's if you're eating all the fat that's on it. And a lot of people are trimming that off. A therapeutic ketogenic diet, for instance, is usually in the neighborhood of 3-to-4-to-1 of fat grams versus protein grams. So that's why I was saying it's a very high fat diet. So because of that, people on carnivore diets may not have those high ketone levels if they're monitoring them, but they're still in a ketogenic state, again, because they're primarily using fat for energy. That may be coming from your body fat, by the way. You don't always need to eat the fat that you want to use for energy. We hope, for a lot of people that are dealing with obesity, right? The goal is to use that fat, burn off that fat. So that's kind of the picture that we deal with.
Yeah, love that. Do you think there's a place for statins?
No, I really don't in the patients that I deal with, right? And the caveat here is if you don't have insulin resistance and if you don't have inflammation, there is no reason that we need to lower your cholesterol with statins or any other method. Now, if you do have metabolic disease, right, you do have inflammation, you do have insulin resistance, there is going to be some benefit to lowering your cholesterol. That benefit is smaller than it's, purported to be commonly. It comes at the cost of side effects from these medications, which are probably higher than they're usually appreciated. But if you're not going to address the insulin resistance and the inflammation, then yeah, there may be some benefits to taking statins or other medications to lowering your cholesterol. You're going to get much more benefit, though, from addressing the insulin resistance, addressing the inflammation. And once you do that, you no longer need cholesterol lowering medications.
Okay, that's super clear. When it comes to, there's this new I'm going to butcher this, I'm very sorry, but you might have to help me out. There's this new injection thing, which name I forget. What mechanism does that play on, and do you think it has a role? Do you know what I'm talking about, that injection thing?
Yeah, so these are the PCSK9 inhibitors, they're called.
Thank you. That's it.
And they are even more powerful than statins at lowering the cholesterol level. They work at a different point in the cholesterol cycle, right, than statins do. Broadly, what I can say, keep it simple, is statins kind of interfere with the production of cholesterol. PCSK9 inhibitors interfere with the cholesterol reprocessing in the liver, essentially. So you kind of end up recycling less cholesterol, and that causes the cholesterol level to drop. So they do work by different mechanisms, and because of that, they may have different side effect profiles, right? Different side effects that all medications have. The choice between the two, right? People say, because there's been a lot of discussion around, statins and their side effects. And so people might logically say, okay, maybe these other medications are a better way to lower cholesterol. That may be true in certain circumstances, but I always take the step back with the patient and say, is there going to be benefit to lowering your cholesterol, regardless of the method, right? And like I said, if you don't have inflammation, you don't have insulin resistance, there isn't going to be benefit to lowering your cholesterol. So I don't care which method you use, right? They all are unnecessary. So why would we expose ourselves to the potential risks of these medications?
Yeah, I imagine it gets dangerous as well when people say, "Oh, it's working because my cholesterol is so much lower." But yet, when you uncouple it, as we have to, you eloquently have today, you realize that actually doesn't correlate with your risk of getting heart disease. Very interesting.
Exactly.
Am I right? A little rumor, a little birdie told me that you were featured in the Cholesterol Code documentary. Is that correct?
No, I'm not in that one, but I know Dave Feldman well, and I'm looking forward to that documentary. There are some other health-related films that are coming out, metabolic health-related films that I have been in.
Oh, I see.
Yeah.
What do you think something like the Cholesterol Code coming out will pop this bubble in a way we haven't seen before?
I think there's a lot of things happening now that are going to start to help us, unravel this false narrative around cholesterol and get the benefits of metabolic health out there, right? And I look at, like I said, cholesterol code. I know of a couple of other documentaries around metabolic health, carnivore diets, low carb diets that are in the works as well. The more we can get this information out there, the better. And the other thing that makes me more optimistic is the, information environment around health is starting to change as well. Because of what we went through with COVID, people are starting to realize how problematic, the filtering of the information has been. And, we have better direct information sources these days, right? We have podcasts, we have the social media platforms. We can get documentaries out there when before, it wasn't as easy to get this information out there. And then, here in the United States, we're optimistic. And again, it's not a political issue. It's just a fact that the new administration is talking about health. And RFK, Robert Kennedy Jr., who's leading that charge, is cognizant of, does believe in metabolic health. So it's going to be part of that discussion. And that is what has me optimistic. I go to conferences. I oftentimes speak at conferences that are centered around metabolic health. I'm starting to see more and more physicians there from more and more specialties, right? We talked about earlier how metabolic health isn't just heart disease. And so this is catching on. There are more and more people talking about it. Podcasts like this are great platforms for people to learn about it. And that's what has me optimistic about this movement that's going to be centered on reversing this pandemic of chronic disease that we are under, and doing that via a metabolic health centered approach.
It does feel like there's this lovely communal aspect to this metabolic group, and all just very well-intentioned, rational people trying to push a good message founded in great, credible science, right? And I think it's interesting. 5 years ago, the science is still good, but it's not quite where it is today, and that's only getting growing at a more exponential pace. So yeah, I agree with you. I'm very optimistic as well. It's exciting times. I'd love to end with some quick fire questions, if we may.
Sure thing.
Do you have a favorite meat?
Steak.
Yeah? What cut?
I lean towards the ribeye as well, the fattier cuts.
Birds of a feather, me too. I'm, and growing up, I was like, oh, I love all the fatty meat. It's the best, but it's going to kill me. And this is great news, right? We talk about education a lot in during this episode. Do you have any books that would be good for starting for someone who's like, okay, I'm pretty new to this whole metabolic health keto thing? Any books that would be good to start, and then broader, any books that you would just recommend to the audience that you like in general?
Yeah, I mean, of course, shameless plug for my book, right? Stay Off My Operating Table. I think it is a good high-level overview of this, and written to be very understandable and digestible. I love Ben Bickman's book, Why We Get Sick. That's a great one. And then I go to the book that started it for me, right? And by now, this is considered an old book, right? But Gary Taubes' original books, Good Calories, Bad Calories, and The Case Against Sugar, are great starting points for understanding, metabolic health at its roots.
Beautiful. What's the most misunderstood lab test?
I'm going to have to say LDL cholesterol.
Do you have a typical range that, or do you think that even trying to higher or lower is just completely, it doesn't matter?
Yeah, like I said, if you don't have insulin resistance and you don't have inflammation, there's no reason to even pay attention to what your LDL cholesterol level is. It's a truly meaningless test in that setting.
Okay, good. I appreciate you've answering that a couple of times for me this episode. But it's like Churchill said, the key to good oratory is repetition, repetition, repetition.
Yeah.
So appreciate that. What's the worst health advice you see on social media?
Eating a low-fat diet has to be the worst.
It's funny, you talk about this low testosterone epidemic as well, and lots of people seemingly suffering with it as well. I imagine the effect of statins and anything to lower cholesterol would have the same effects as well.
Yeah, metabolic disease in general lowers your testosterone level. So, eating a low fat diet may contribute to that as well. But just being metabolically unhealthy, which by the way, usually results from eating a low fat diet, because if it's low fat, it's going to be high in carbohydrates. That's just the nature of the beast. We got to eat something. So low testosterone levels should be a red flag for metabolic disease. And one of the things I talk about with men often is the solution isn't go get your testosterone shots, because you're not addressing that underlying problem, and that metabolic disease that's causing the low testosterone is going to persist and lead to other problems down the lines.
Yeah, I've not heard someone tie those two together, and it's a really interesting angle. If you could put something on a billboard for everyone to see, what would it be?
Probably the thing that I would focus on most is to get people to get a coronary artery calcium scan, a CAC scan, because that's the early warning test. We haven't really talked about it, but that shows you the blood vessels in your heart and what's going on. And that's one of my sort of pushes, is that test needs to be utilized more often. And my hope is that when people then see the heart disease at the early stages, they'll start coming across and recognizing it's coming from metabolic disease, and now we can address that.
It's an uplifting message, because it doesn't mean they have to go and get some drug that they've never heard of and can barely pronounce. They just have to get their metabolic health.
None of this is about, pharmaceuticals. One of the other things that's central, and maybe this is another good thing to put on the billboard, right, is that we as individuals can take charge of our health. We have the power to heal ourselves. We don't need the pharmaceuticals. We just need the right information that will lead to us adopting the right habits. And that's how we improve our health. So take back control of your health is another kind of billboard message that we have.
So good. In a weird way, I kind of wish you less business, but I don't at the same time, right? You're doing good work at both ends of the spectrum of helping people prevent getting on your table, and obviously fixing their hearts when they do. This has been so fun. I've learned an absolute load, and I'm sure our listeners have as well. Where can we find you? Where can we keep up with your work?
Yeah, so iFixHearts is really where to find me everywhere on all the social medias. You can go to ifixhearts.com. You can connect with my team. I have a telemedicine practice. We see patients throughout the United States and worldwide. We have international patients. So come to ifixhearts.com and you can figure out if we're a good option to work with for you.
Brilliant. Well, Dr. Ovadia, I really appreciate you coming on. It was super fun, and we'll have to do another one down the line when the research changes, perhaps. But
definitely so. It's been a pleasure, and thank you for all the work you're doing to spread this message.
Thank you so much. Appreciate you.